Hello and happy Teach Me Tuesday. My name is Lisa. I'm a NICU nurse educator and an experienced NICU nurse here to bring you NICU topics broken down into little bite sized chunks. Today, we are going to go over medications commonly used in the NICU. And I want to tell you two things. Number one, medication doses can change over time. So it is August of 2025. I don't know when you're watching this video, but number one, you need to always go and check your own resources for dosing. Number two, I'm going to do today's video a little different because the information is on the text and there are 16 slides today, which is longer than usual. So in order to keep this short, I am going to just talk something unique about each one, let you kind of read the slide and give you time to pause, screenshot, do whatever you need to do. But know that if you have further questions, you can always find me here or on social media. So let's dive in. We know that medications are the cornerstone of NICU care. And what I'm going to go over today is just some of them, some of the common medications. We're going to go over 12 meds. And this is in addition to the ones we did last week for respiratory meds. So totally different. Some I will tell you, you can go back and see previous Teach Me Tuesdays about. But what we really need to know more than anything about these medications is the mechanism of action, what we as NICU nurses should be looking for, and how we can best explain and help parents through this. So I hope by the end of this, you get that and you've gained confidence and really anticipating the needs and recognizing adverse reactions and helping the families through that. So the plan is kind of common to uncommon, right? So Amp and Gent, right? Amp and Gent are the most common antibiotics we use in the NICU. That is because they are the broad spectrum. They are the ones that kind of can cover everything. And so until we know what a baby has, we want to start broad. And that would be Amp and Gent. So the dosing of this specifically, I want to call out on this slide, is different for ampicillin based on how old the baby is. If you are a preterm baby, you're going to get it Q12, and if you're a term baby, you're going to get it Q8. Gentamicin also has been having changing in kind of the dosing in the last few years of my career. I've noticed changing there. And so I really want you to pay attention to it. We used to give gentamicin 5 milligrams every 36 hours. That was it. And now, kind of depending on what you're getting it for, if you're a brand new baby or you are a baby that's been in the NICU for a month, it's really going to depend. So that's when I encourage you yet again to go back and check your resources. Amp and Gent, I think we all know them, right? I call them the starter pack, but you kind of get what I mean there. D10, huge med we use. We use it for lots of IV fluids for our late preterm term babies to give them when they first are admitted to us. We give it for a baby if they get sick and they need access before they have a central line. And then we also use D10 as a bolus medication to give babies with low blood sugar. And that's what I want to focus on here. We can give D10 as a bolus for sugars, typically less than 40, maybe less than 50, read your unit policy so you know what it is. And it's always 2 mils per kilo. I have seen this mistaken with a normal saline or lactated ringer's bolus for a blood pressure problem, which is 10 mils per kilo. That is not what you want to give for sugar, right? You want to give something quick, concentrated, that's going to bring that sugar up. And you should always be following that up with a blood sugar within 30 minutes after giving an IV bolus of D10. So that's a key takeaway I hope you have from this one. In the NICU, also very common is vitamins and supplements. We give vitamin D, we give iron, we give multivites. Big thing about here is if you know the baby's going to go home on these and the baby's doing PO feeds, have the parents start giving them right away. I have seen a baby being discharged where the parent has never drawn it up and never given the bottle that had the vitamins in it. And we NICU nurses know that it is very tricky sometimes to get them to take those vitamins, especially the vitamins with iron that are kind of stinky and thick and, probably taste bad. I've never tasted them, so maybe they taste bad. So I encourage you to have the family present for those bottles so that they can draw up the medication and be the one to give the baby the medication. So, huge nursing tip there. Morphine, fentanyl are kind of two big common medications that we give for analgesia, for sedation. There are some others that we are using more and more, Precedex. There's others out there, but these are probably the most common. We can give them both as PRN IV pushes and continuous infusions. Make sure you know what the concentration of your medications are when calculating your fluids for this and when calculating your drip rates. What I want to make sure you know here is that fentanyl can cause chest wall rigidity. In fact, we stopped using fentanyl in one of the units I worked in because of this. And so we went to only morphine. We used to kind of do both. And so we went to only morphine. If it is given too rapidly, it's not great, right? And so really it should be given on a pump. I see people push it, especially in small doses, because you think it's going to get lost. But being given on a pump is really the most cautious thing you can do and the best thing you can do to help prevent this. If you're giving this for something like a rapid sequence prior to an intubation, I would always have your providers ready when you're giving the fentanyl just in case something goes wrong here. So that is a big key takeaway for our fentanyl. Ibuprofen for PDA closure. So when I started, we only gave indomethacin. That was the only medication we had available, and we often just gave it to anyone born under 25 weeks in the first, about week of life. We don't do that anymore, thank goodness. Now we're giving ibuprofen. Ibuprofen inhibits prostaglandin synthesis. So when I think of that, what I think is PGE and ibuprofen are opposites, right? PGE is meant to keep your PDA open for your congenital heart defects. Ibuprofen's like, let's bring those things closer together, that walls of the PDA, so that we stop having blood flow through there. So keep that in mind as your mechanism of action is really important to know why you're giving it and what it's going to be doing in there. And hopefully it's going to work. We also give acetaminophen for this. That's a newer medication for PDA closure, but that's something else you may see as well. Hydrocortisone. Okay, what I want to give you as a key takeaway here is my frustration in trying to find a standard dose for this, because you can give hydrocortisone for a few things. You can give it for if a baby is having chronic blood sugar issues and you're working them up for something, hydrocortisone is something that we give for that. It has a dosing schedule. You can give it for blood pressure support, either usually first or after, if you're trying to get them off dope and dopamine. Sometimes we give it as a way to prevent them from going on. And then sometimes we get it as a way to get them off. And then sometimes we use it as a steroid for BPD. So the first thing you want to know when you're giving hydrocortisone is, why am I giving it? What am I treating? And then from there, go and find your dose. So that is my key takeaway to you. Is you might be looking at these doses and be like, I've never seen someone being given 5 mg per kg per dose. Well, it does happen sometimes, especially in long-term BPD kids. So go check that out. Make sure you know what your dosing is and know what the dosing is per the indication that it's being given. We talked last week during our respiratory about Lasix, but we do give other diuretics. So chlorothiazide, Diuril, something else that we can give. One thing I really want to point out here is that oftentimes we give this PO for kind of chronic kids who are a little bit older, and we have stopped checking their diaper weights. We are no longer doing strict output. And because of that, you want to make sure you get that reordered. And in those first few days, you're really checking what their output is to make sure we're not getting behind. So that is a key takeaway for this one. If your baby is getting diuretics, they were not on strict output or diaper weights, whatever you want to call it, get them back on that. And of course, sometimes we then need electrolyte replacement, which you're probably thinking to yourself, sometimes these things go back and forth. But what I want your key takeaway here is, these are not things that are going to be replaced like this, especially when they're given PO. So you're probably going to get your electrolytes drawn about every week, maybe after 3 days, the first week, but this is going to take some time to change. So give it time. Think about that when it's going through, when you're giving those medications and you're like, oh, why aren't we checking this more often, or what's going on here? Keep that in mind and make sure you know kind of what they're looking for, what they're going to think is an ideal number, and then when they would consider weaning them. So all of those kind of go together. Is it can take a while for it to come up. What are you looking for? What's an ideal number? And when can we start weaning? Dopa and dopamine, we did cardiac meds in February. You may remember if you've been around for a minute. So you can go back and watch those Teach Me Tuesdays. We go into way more in depth in here. But what I want to especially point out is how sensitive babies can be to this and how we sometimes need to give them time. So especially depending on your line. Dopa and dopamine are ordered in micrograms per kilogram per minute. So when you're setting up your pump, make sure it's ready to go like that. But from there, You do not want to be titrating it every 1 minute, right? You should have titration orders based on what they think the blood pressure should be and where you're getting that blood pressure from, whether it's a cuff or a UAC or a peripheral arterial line. And so in doing that, know what you're looking for and then do your weaning or your escalating and give it time to respond. So that can be harder, and especially if you have a central line that's going to respond faster. But with your cuff pressures, even cycling a cuff pressure every 1 minute doesn't really mean much to me. I would still be putting it on probably an every 10-minute cuff cycle to see what my effects of dopamine and dopamine are. Acyclovir, right? Acyclovir is given for presumed or known HSV infection. Big thing about this is it is incompatible with everything. So make sure you look up those incompatibilities. Often it needs its own line, or you have to stop what you're running in order to run your acyclovir in. So make sure you check whatever fluid you're running against this before you start it. I decided to include this because I don't know if you know this about me, but I hate ROP checks. It's like one of those things in the NICU that I've just like not gotten better with. I get like nauseous watching it. And so I just feel like everybody should know about them. But cyclomydrol is for ROP checks. It is to do pupil dilation, and they can make a baby bradycardic. So I think that's something to really think about is that it can increase apnea and bradycardia. If I'm a night shift nurse receiving report, I want to know if the baby got an ROP check that day, when their last drops went in, and if they did have a change in their apnea and bradycardia. Because if they do overnight, then I can kind of be like, okay, is this something that I could relate to that ROP check? Or is this something that I need to escalate because it's looking more concerning? So, just things to think about. They can destabilize your fragile babies, and also they hate it. They hate eye checks. So, kind of all goes together. IVIG. So, IVIG, we did also talk about a little bit during our bilirubin lecture, hyperbilirubinemia. You could go back and check there. We don't use it that often, but it really has to do with this severe isoimmune hemolytic disease. This is something that I've primarily seen in hydroptic babies and in babies that have very high bilirubin in a very short period of time. This medication also has a wide range of dosing, and I think it's really going to depend on kind of what you're doing and why you're giving it, how often it needs to be given. This is not considered a blood product, and I know that that has been a controversy in a unit I worked in over time, but it is not considered a blood product and is not something you need to receive consent for. It is considered just a typical standard neonatal medication. So something else to really think about. Um, if you're going to give this, I do suggest looking it up prior, making sure you kind of have a really thorough understanding of why you're giving it, especially for this. So if you are of a baby with a really high bilirubin, we want to reduce hemolysis, right? Because when the red cells are breaking down, they're releasing that bilirubin, which is going to drive your bilirubin higher. So that's what we're doing here. That's its mechanism of action. So keeping that in mind as you are treating this baby. So that was 12 meds really fast. I did talk really fast. I did try to just pinpoint on one thing you would need to know. This is a video, right? You can go back, you can pause on the slide and rewatch it, relook at it, think about what you were seeing and kind of how that would affect your practice. But really, need to think about our parents. And we did talk about this last week during respiratory medications, but the parents should know why their baby's on the medication and to say to them, oh, did someone talk to you about caffeine? Did someone talk to you about Ampingent? That doesn't really give you an understanding. So making sure that they can teach back to you, that they repeat instructions, both about why the baby's getting the medication, what they should be looking for, and then especially the baby's going home on the medication. If they're going home, giving them written instructions, making sure they've practiced those medications, especially even vitamins seem so simple to us, but they're not simple to the parents. So making sure they've practiced drawing it up and giving it, and then giving them really trusted websites that will help them understand what they're going to do at home, who they can call, when the med will get rechecked, what the pediatrician needs to know, and is where they need it to get it filled, especially is it going to be filled before they go home, which it should be either at the bedside or on their way out the door, and then where can they get their refills. So those are lots of things that we can help them with. But it starts with in the NICU, even that little 24-weeker, explaining to the parents why they are on this medication so that they have that understanding and they feel a part of the care team. I also always like to explain to parents what we're looking for a baby to be done with that. So even if I'm talking about caffeine, if I'm talking about amp and gent, if I'm saying your baby is brand new, your water, was broken for 48 hours, we're going to start amp and gent and we're going to recheck that blood culture at 48 hours. And if it's negative, we're going to stop. If it's positive, we're going to look for more specific medication to give your baby. And that would be our next step. So in 48 hours, we will know what the next plan of action is. Gives them a time frame. It takes some of that worry away. So medications in the NICU range from things we use every single day to things we use so infrequently. Understanding drugs, knowing what your resources are. I really like Micromedics, which has Neofax built in. I really like Up to Date. I think Up to Date is a great resource because it tells you exactly when they just updated it, and it's usually up to date. So it always makes me feel good. Printed resources always be tricky. Just like I told you at the beginning of this video, it is August of 2018. 2018. Whoa, no, it is not. It is August of 2025. And maybe things have changed since you've been watching this. So go to your go-to resources for incompatibilities and dosing all the time. So important. I cannot stress it enough. But stay curious, stay confident, and you will be successful at giving medications in the NICU.